Everybody, welcome. So excited that Dr. Rosenthal, Julia, is here with us. And please, let's just start off. Tell me a little bit about yourself. Well, actually, before we do that, I just want to give you a shout out. I met you on Instagram last fall. You were running for, in the American Physical Therapy Association, we have different sections, and there's a section that's been called Section on Women's Health, and Julia was running for president of the
Early Professional Special
Interest Group. And so that's how I first met her, and she won the position, and I'm so excited with all the things that you're doing in the section. So that's super.
Thank you.
And then we got to meet at Combined Sections meeting in Washington, D.C., so that was cool too.
Yeah. Thank you so much. So I am a pelvic floor physical therapist. I work in New York City. I did my residency. I did an orthopedic residency through the Harkness Center for Dance Injuries. So that was where my specialization in dance came from. And while I was there, I got to treat some patients with pelvic floor dysfunction. And I even got to teach some of the other clinicians there how to screen for that in their hip and low back patients. So it was a really, really great learning opportunity. And then I moved to Beyond Basics Physical Therapy, where I now treat a wide variety of pelvic floor conditions. So it's been a really great learning curve, and I'm excited to be talking about this topic.
Oh, good. I didn't even know you had that background in the Institute, so that's fabulous. I'm looking at our content today, and it's wonderful. So let's just jump right in then. Tell me, how common is pelvic floor dysfunction in dancers or female athletes?
Much more common than we think that it is. There was actually a study done kind of a while ago, 2002, but still, it was looking at urinary incontinence in elite female athletes. And even though over 50% of them reported that they had some urinary incontinence symptoms, only 3% of them were telling their doctors about it. So it's really common, but people aren't really reporting it. And that's just incontinence. So that's just one type of pelvic floor dysfunction. And if you think about what might be happening in a dancer who's probably overtraining and overusing muscles, that's probably not even the most common type of pelvic floor dysfunction in that population.
Very, very interesting. That is, we know that people are not likely to talk about pelvic floor dysfunction, but even less in athletes. So
yeah.
Great information. So what are some of the risk factors for pelvic floor dysfunction in the dance community?
There are lots. Many of them are things that are risk factors in the general population as well. But dancers are at particular risk because of scoliosis, which has a high incidence in the dance population too. Faulty biomechanics is a big problem. Repeated motions, like training at ends of range over and over and over again, and using the same limb over and over and over again. They do a lot of jumping, so there's a lot of demands on regulating intra-abdominal pressure. And they also have a higher incidence of things like abnormal eating patterns and dysmenorrhea, which can contribute to pelvic floor dysfunction too. So both from the physical demands of dance and from the aesthetic demands of just being a person in the dance community, there's a lot of things contributing to potential pelvic floor dysfunction in that population.
Very good information. Okay, so can you speak a little more on the ways in which nutrient deficiency and menstrual abnormalities may impact the pelvic floor in the dance population?
Yeah, so I touched on that a little bit, but essentially dancers are at a much higher risk than their peers for having disordered eating at all. There was actually a study that showed that they were at a 3 times higher risk than their healthy female dancers, were at a 3 times higher risk than their healthy counterparts, which is pretty significant. And there was another study that showed that the dancers who were demonstrating those eating patterns were also demonstrating higher rates of both anal and urinary incontinence. So now we're talking about multiple types of pelvic floor dysfunction related to disordered eating. And if you think about things that people might do to contribute to a disordered eating problem, they might be abusing laxatives, they might not be eating enough. So they might be having more constipation, more diarrhea, and we know as pelvic floor therapists that those things are going to contribute to pelvic floor dysfunction. So it's kind of like a chicken egg thing when it comes to the pelvic floor, dietary habits, and just general gastrointestinal health.
They're trying to keep the look.
Absolutely, and it's part of the problem too is the messages that they're getting. It's not even all intrinsic. So as a provider for that population, being able to have that conversation is really important.
So dancers have very rigorous training schedules. So how can overtraining play a role in pelvic floor dysfunction?
Yeah, so if you think about, like, if we define a high-intensity athlete, people have defined that from a variety of hours of training in a week. But there was one study by, I believe it was Tiessen et al. In 2002, where they defined it as 8 hours of training in a week. And if you look at a professional dancer's schedule, that person is probably dancing at least 30 hours a week. So just right there, there's so many more opportunities for overtraining injuries in dancers, whether that's a pelvic floor dysfunction, a low back injury, a hip injury, foot or ankle injury. All of those things are at increased risk in that population. And we also know that overtraining can lead to, dysfunction in your dynamic structures, which includes the pelvic floor. So the things that tend to overwork in dancers might include structures of the pelvic floor, like obturator internus, things related to the pelvic floor, like piriformis, hamstrings, psoas. All those muscles are high demand muscles in dance. So overtraining in those areas can lead to musculoskeletal dysfunction in general, but definitely pelvic floor dysfunction too.
Because those muscles are trying their hardest to do what's required of them, but they can only do so much. And
Absolutely.
Results.
And it's a population where, like, end range is the desired aesthetic. So people are forcing themselves, if they don't have it, people are forcing themselves into these end range positions, and then something is going to have to stabilize them there. So if they don't have it from the hamstrings or the glutes or whatever else could stabilize them there, the pelvic floor is ultimately like the central locus of load transfer and stability. So it's going to recruit more in those positions.
Very good information. Okay, so we talked about overtraining. Can you go into a little bit more about some of those structures and the impact there? Some examples.
Yeah, so especially in ballet, but in a lot of different types of dance, any kind of dance requires working in a really max turned out position. So that's max end range hip external rotation. And the muscle there are lots of muscles that do external rotation, but obturator internus specifically does external rotation in an extended hip. So that's a person standing in their basic first position is going to be using their obturator internus. So that muscle is going to be at definitely a risk of getting overworked. And if it is, it can be a problem for continence because the other pelvic floor muscles, the levator ani group, can't generate enough pressure on their own during higher intensity activities to maintain continence. So they need help from neighboring things like obturator internus and piriformis to maintain continence. And if there's extra demand on those muscles, they might not be as available to help with that.
Good. Great.
So that's one. Psoas is another one. Psoas is like the pelvic floor. Psoas is a hip stabilizer. But if you look at dancers who are doing these like long extensions of their legs overhead, the psoas muscle really has to work hard to maintain stability of the hip in that position, but also to get that leg overhead and maintain stability of the pelvic ring, which is going to torque in different ways to achieve that position. So it can get overworked, which can contribute to anterior hip pain, which is a major complaint in the dance population.
Sorry, because we have some that aren't medical on the on here. So just can you elaborate a little bit on where someone could find the psoas? It's at the front of the hip.
Yeah. So here I have this pelvis model, which unfortunately doesn't have a psoas on it, but the psoas muscle will connect. This is L4 L5, L4, and then above it you've got 3 more lumbar vertebrae, and these 2 upper lumbar vertebrae is where the psoas will originate, and then it'll pass down this way across the front of the hip here, and then it'll attach to the front of the hip so that if your hip joint is here, it can bring the hip into flexion. So like if you're a dancer, think about motions that will bring your hip up, like going into a passe and going from a passe into a développé. So anything that's bringing that leg up into your extended position, you're going to need your psoas not only to do that, but also to stabilize the hip in the joint and make sure that all the little things that could get pinched on the way get out of the way. That's another part of its role.
Good. Excellent. That was a great description. Thank you for that.
Sure.
Okay. Excuse me. So I think we had some other examples here.
Yes. So the adductor muscles are another really important muscle group in dance. Those, for those of you who are dancers on the video, those are the inner thigh muscles. And they are really, if you imagine being in a turned out position, then your hamstrings are no longer straight behind you and your quads are no longer straight in front of you. So your adductor muscles are going to help you keep that kind of like legs together position that you need in that first position. And then as you move, as you separate your feet into a second position, or even bring your legs kind of across each other in like a fifth position, for example, those muscles are really going to help you maintain that position. But those muscles also have a direct connection into the front half of the pelvic floor. So here's my model again.
Yes.
This is the urogenital triangle, okay? Right underneath these more superficial muscles, you have your urogenital layer of muscles, and those muscles share a connection with your inner thigh muscles, which come up this way and attach to this same bone right here. So when those muscles get tight, you could have more urinary urgency, urinary frequency, and pain in that groin area because of tightness and overuse injury to those structures. So that can be a really big reason to take a look at the pelvic floor, even if it's not a pelvic floor specific complaint. So if a person, adductor strains, for example, are really common in the dance population. So if a person comes in with an adductor strain, we should be looking at the pelvic floor muscles because there's a relationship there. So even if it's not the chief complaint, it might be contributing to what the person is experiencing.
Super. You are giving me so much information. All these dance terms. I love that you're in this population. So that's very good. Okay, and then piriformis.
Piriformis. So like the obturator internus, piriformis is also a small external rotator of the hip. So it's working really hard a lot of the time to maintain your turned out position, but it can do external rotation at more degrees of hip flexion. So when you are standing on a straight leg, your obturator internus is going to work more. When you start to bring your leg up higher, your piriformis is going to start to work more. So you might start to get a little more use of that muscle in that position. And if you think about where it is, you have your obturator internus kind of makes up this front side wall of the pelvis. And then your piriformis, it's not on here, but right where that hole is going to be covered up by your piriformis, which is right here. Okay, so it's making up a wall of the inside of the pelvis. That means that if it is overused or injured or tight or whatever you want to call that, it's going to affect these other muscles because it has a direct relationship to them. So kind of like the adductor strain person, you want to think about those other muscles if a person's coming in with what you might think of as like a piriformis syndrome or radiating pain down the back of the leg, because the small rotators of the hip will always have a relationship to the pelvic floor muscle.
Good. And they're all meant to work together.
Absolutely.
Yep.
Absolutely.
Okay. So what is the relationship between hip and low back injuries in dancers in the pelvic floor?
Yeah. So like we touched a little bit on how one of the chief roles of the pelvic floor is hip stability. So if you have any injury to the hip, so think about people in the dance community will know that a lot of times dancers will get pain in the front of the hip, pain in the side of the hip. They might be diagnosed with labral tears. They might be diagnosed with hip impingement. All of those things will compromise hip stability. So if you have a compromise in hip stability, you should be assessing what the pelvic floor muscles are doing, because that's part of their role. And if the joint is no longer providing that stability, the pelvic floor muscles might start to work extra hard to provide that stability that isn't there. So that's one way. The other way is that different holding patterns, which I think we're going to get into in a little bit, will ask the pelvic floor muscles to work extra hard in the dance population. And so if that's happening, you're going to get stiffness in the pelvic rings. When I say pelvic ring, I mean basically all of this. So you have all these muscles in here, yes, but you also have joints making this ring. So you've got your pubic symphysis, and then you have your sacroiliac joints in the back. So you can imagine how if these muscles are tight and pulling together, they might limit the mobility of some of these joints here, and maybe even the lumbar spine, and definitely the hip, because some of these muscles are attaching to the hip. So if the range of motion is compromised somewhere, the dancer is still going to try to achieve that end range position for the aesthetic. So they're going to compensate somewhere. So they might get more low back motion. They might arch more in their thoracic spine. They might try to cheat their hip extension with a little extra hip external rotation, or torque their pelvis to try to make it look like their leg is further behind them. So all of those things are going to contribute to possibly symptoms in one of those other areas neighboring the pelvic floor, and it can all come back to the fact that they don't have the dynamic mobility of those muscular structures in the pelvic floor.
Because something's got to give. They're trying to exceed that, and one way or another, their body's going to find a way.
Absolutely. And then the other thing, too, is that different hip and low back injuries can actually cause pelvic floor dysfunction. So in my preparation for my talk that I gave last weekend, I read this very cool study that they did on rats, where they gave them a sciatic nerve injury, and the sciatic nerve injury was known to cause pain in the hind paw, so basically leg pain in the rat. And then they observed the rats for the next month, and they found that all of the rats had increased urinary frequency for that period of time. So they had given them a sciatic nerve injury that's not a pelvic floor injury, but it was creating some visceral hypersensitivity. So even something that is not necessarily a pelvic floor function can create symptoms of pelvic floor dysfunction. We just have to sort of be on the lookout for that as providers.
Great. Very good information. Okay, so you mentioned abnormal chronic holding patterns as a pelvic floor dysfunction risk factor in the dance population. What are some of the ones that providers treating these cases can look for?
Sure. So there's lots, but some of the ones that you'll see the most commonly are the ones that are going to change how a dancer feels their turnout. So one of those is an anterior pelvic tilt. So if you think about that, so here's a person just standing normally, okay? And then they might do an anterior pelvic tilt, which means this, okay? So here, actually, I have another model. Whoop. Okay. So if you think about what that's going to do a little more up the chain, anterior pelvic tilt is going to do this. So look at the spine, okay?
Look what happened to the lumbar spine.
It went into this kind of like forward bendy thing. Okay. So anterior pelvic tilt is something that dancers will do a lot if they lack hip turnout, because the hip will have a little more space in the front of the joint if the pelvis is in that forward position, which is going to allow them to get their toes out to the side a little bit further. If they do that, they're going to have to hold really hard to stay in that position, because that is not their natural turnout. So some of the muscles we've already talked about are going to be working extra hard. So that's going to be obturator internus, piriformis. Those muscles are like holding on for dear life to try to keep that dancer in that turnout position. That's problem number one. Problem number two, your lumbar spine is now in that extended position, and your ribs are going to go into that kind of like flared out position. So your diaphragm is going to be a little stretched. It's not going to be able to be efficient. We'll talk about breath holding in a second. But so that's going to be a problem. Your transverse abdominis, which is your deep core muscle in the front, it's like it kind of covers your whole abdomen in the front. It's going to get elongated and stretched. Anytime a muscle gets elongated from its kind of like natural neutral position, it's going to have a slightly harder time doing what it's supposed to do. So now we've got diaphragm is a little elongated, transverse abdominis is a little elongated, the obturator internus and piriformis are elongated, and your weight is like in front of you a little bit. So the things that are behind you aren't going to be as efficient at holding you up, and your adductor muscles, those inner thigh muscles, are going to work even harder to hold you up because that's what's there. That's what's in front of you. So I just listed almost all of the muscles that I talked about related to the pelvic floor that could be a problem and contribute to pelvic floor dysfunction in dancers, and that's part of why an anterior pelvic toe position can be an issue.
Yeah. I want to interject just a very simple analogy of the lengthened. So think about your wrist flexors, right? So they're here and they're moving nicely. But what if you're back here? How much harder is it to work in this position if you were to lift something? So it's the same concept, overstretching the muscle in that super lengthened position.
Right.
Good. Keep going.
Right. And the other thing is that a lot of those muscles, like you said before, those muscles have to work together. So if one of them is, like you said, all the way back here, not doing its job as efficiently, then the other ones are going to have to double up so that they can do more. And that's going to mean more stiffness, less dynamic mobility, and more dysfunction. So if some of the deep core muscles, all the deep core muscles work together, the transverse abdominis, which I mentioned, the diaphragm, the multifidi, which are like these little muscles in the back that are segment by segment, and the pelvic floor work as this kind of like canister of stability, think soda can, all right? And if all of the ones above the pelvic floor are lengthened or doing something funny, then the pelvic floor is going to try to do more to create that stability. So that's going to feed into some possible pelvic floor dysfunction if you're seeing that pattern. Another one is the opposite, is a posterior pelvic tilt. So we talked about what an anterior pelvic tilt is. That's this. A posterior pelvic tilt is, my model's not going to do this very well, but that. All right. So the low back is flattened. Yeah. See the butt and is kind of like tucked under. And the tailbone is kind of like pointing forward a little bit. So dancers might do that because a lot of times in a turned out position, one of the aesthetic demands of that is they'll be cued to achieve a flat back. So they might do that because they're trying to achieve that flat back position, but they don't have enough turnout from the hips to maintain that position. So they're going to squeeze everything behind them trying to get that flat back. And the other thing they might be told is to use their glutes. They might be cued to use their glute muscles. So if they do that, they're going to squeeze their butt really hard to try to feel that. But a dancer should be able to use their deeper external rotator muscles like obturator internus, piriformis, and the other little ones that are in there, the gemelli and all of those things, to maintain that position without visibly squeezing their glutes. So if you see them visibly squeezing their glutes, there's a good chance that they're over-recruiting the pelvic floor muscles towards the back of the pelvic floor, and that will lead to all of the other things we already talked about with too much stiffness in that area and have other carryover effects. So one of the other things that's kind of interesting about that one is a lot of times you can identify a dancer just because of the way they walk. They're going to walk kind of like turned out, sort of like moving their pelvis a little more, very proud, and the kind of like chest elevated. And that is possibly a sign that they're using that kind of glute gripping
Very
strategy.
interesting.
Yeah, even in standing, walking, all of those daily life activities. So making sure that you're addressing them in those daily things and in dance is really important. So when I was working a lot with dancers, I would say, think about dancing think about walking and stairs and all of those things as cross training. You're not dancing when you're walking down the street, so you don't have to be in turnout. So that's just, yeah. So, and they might be dancing more than they're walking, right?
Yeah.
But they should be able to they should have that variability in what they're going to do with their hip.
Good.
And then the last one I just want to quickly touch on is breath holding, because as I said before, the diaphragm, the pelvic floor, the transverse abdominis, and the multifidus all have to work together to provide core stability, which is really important because your limbs are going to all of these super end range positions, and you need some central stability for distal
mobility. Right.
So if something is on stretch or inefficient in that system, then all of that system is a little compromised. So if you're holding your breath, you're not going to get that natural up and down motion of the diaphragm. And when you breathe, the respiratory diaphragm and the pelvic diaphragm move together. So you get this kind of like pistoning effect that is happening. And if you don't have that dynamic play of those muscles, then that stiffness is going to throw off your coordination in your breathing and is also going to impair your core stability. So it's really important that dancers breathe while they dance, which sounds so basic, but it can be really hard to do. So that's a really important thing to focus on with them.
Very good. Anything else you want to say about breathing here?
I think I touched on most of it. Yeah. I think the other important thing to think about is that breathing, because those muscles all work together, breathing can kind of turn on your deep core stabilizers. So passive breathing is going to get you that nice passive piston motion. But if you do a forced exhale, then you have to actively use those muscles to lift up. They will passively come up like this. But if you do like a type of breath, then you're going to get this like kind of core brace type of activation. So you can use that to train higher impact activities like jumping or any other high impact activity that's going to happen in dance. Turning can also be a big one. So if somebody's
experiencing, if someone's experiencing leakage with jumping,
yes.
What would you tell them to do?
So I would look at jumping and leaking is a problem that's usually related to pressure regulation. So I'm going to look at what is their ability to do a pelvic floor contraction under different breath conditions. Can they inhale and contract? Can they exhale and contract? Can they maintain their contraction and go through several breath cycles? So it's really important for them to have that variability option. And if they can't do those things, then I'm going to start there and then progressively start training them in different types of contractions with progressive levels of impact activity.
That is beautiful. Beautiful. Good. So we're going to wrap up. So let's just summarize.
Sure.
Concluding thoughts. Yes.
Sure. So basically in dancers, if you have a dancer with a hip, a low back, even an upper back or seemingly rib injury, think about if there could be a pelvic floor component. Look at what their pelvis is doing in space. Watch them breathe and think about how those positions or those holding patterns might be contributing to something underlying that you haven't addressed. And also, don't be afraid to ask them if they're having symptoms of pelvic floor dysfunction. Explain to them what normal urination is. Ask them about incontinence. Ask them about their bowel movements, their dietary habits, their menstrual cycles. All of those things are really, really important in the dancer patient. So exploring those things with them. You might be the first person to do that. So making sure that you're doing that is really important. And then if you're not a person who has the tools to treat that patient, you can make a huge difference just by referring them to a person who can.
It's just bringing up the conversation.
Yeah, absolutely.
So Tell me, for those that missed it, go over that statistic that you had at the very beginning. 3%?
Sure. Yeah, over 50% of elite female athletes experience urinary incontinence, but according to that study in 2002, only 3.3% of them were reporting it to their medical providers. So I'm sure that that's not because the medical providers wouldn't have listened, but they might have just not asked. So if you ask, you'll get the information you're looking for.
And even if you're not a healthcare provider out there, if you're a coach, if you're, any kind of professional that is having dialogue with your clients, I encourage you to bring up pelvic pain, pelvic pressure, urinary leakage. That can be just somebody initiating the conversation. You can make a difference.
Absolutely.
Julia, you have been amazing. I have learned so much. I love your enthusiasm, and I love your special interest here in the dancer population. So I look forward to seeing some amazing posts and more content coming from you. And also, just a shout out to your clinic there, Beyond Basics PT. You're in New York?
Yep, we're in New York City.
Okay, good. So anybody in New York that needs pelvic health, you know where to go.
All right. Thank you so much, Denise.
Thanks. Have a great day. And thank you, everybody, for joining us. And this will be on YouTube within a couple weeks.
Great. Thank you so much, everyone.